both the sessions will be taken by Dr. Ketan. So Ketan is there with me only. He is there next to me, so he will be presenting from the same system. So the stage is yours, Ketan.
Thank you, sir. So,
gram negative, you would have found extensive and exhaustive. But when you read CLSI, you will understand that gram positives are more difficult to understand and apply than gram negatives.
So small information and so tricky. So we'll begin with our gram positive. Let's begin with the first gram positive and the most common pathogen, that is Staphylococcus. So can we begin the poll?
Yes, ma'am.
So yeah, there are 4 questions to be coming in the poll.
4 questions are there. 2 minutes you keep.
Yes, polling is a start.
Yeah, 2 minutes you keep.
2 minutes.
In total,
2 minutes of polling. One minute left. Time is up. Polling is closed now. Polling is closed. Can I share the results?
Yes.
I displayed the result.
Okay. So the first question what we asked was, which of the following methods can detect oxacillin resistance or the methicillin resistance in all staphylococcal species? By all staphylococcal species means Staphylococcus aureus as well as all cons. So we had 5 options. Either it can be cefoxitin based test, cefoxitin MIC, cefoxitin disc diffusion, or it can be an oxacillin based test. It can be MIC based test, disc diffusion, or screen agar. So the answer for this question is oxacillin MIC. We'll discuss why. No, sorry. Okay. Then the next question was, which of the following oxacillin resistance detection methods is recommended only for Staph aureus, not for other Staphylococcus species? The answer for this is oxacillin screen agar. And the next question is, cefoxitin disc diffusion test is a surrogate marker for MRSA or methicillin resistance in which of the following Staphylococcus species? Lugdunensis, in which of the following Staphylococcus species except Lugdunensis, Slippery, Hemolyticus, and Epidermidis? So the answer is Slippery. Except other than pseudo-intermediates and Slippery, you can use cefoxitin disdiffusion for rest other corn species. Pseudo-intermediates and Slippery you cannot. Next question was cefoxitin MIC can be used to detect methicillin resistance for which Staphylococcus species? So MIC can be used for which methicillin resistance in what all staph species? The options were Hemolyticus, aureus, epidermidis, or all of the above. So actually, the cefoxitin MIC can be reliably done for staph aureus as well as Lugdunensis. So we can do Lugdunensis, Staph aureus, and one more is Saprophyticus. So these are the three. We'll discuss all the questions. So aureus and Lugdunensis, they are mentioned in CLSI. That's cefoxitin MIC we can do. Eucus mentions additionally as Saprophyticus, for which cefoxitin MIC can be done. Now we'll discuss it in a bit details. So actually, oxacillin resistance or resistance to beta lactams, primarily the penicillinase resistance penicillins. It can be done by 5 different methods. Cefoxitin based methods, that is cefoxylin MIC disdiffusion, oxacillin based method, oxacillin MIC disdiffusion, and screen agar. Among this, oxacillin MIC can be done for all the groups, aureus, all the different corn species. So this test, if you do, you can do for all these staph species. What about cefoxitin MIC? We can do cefoxitin MIC testing only for aureus, Lugdunensis, as per CLSI. Extra is Saprophyticus, for which Eucus recommends it. What about cefoxitin disdiffusion? It cannot be done for pseudo-intermediates. It cannot be done for Slippery. Other than this, all other things you can do. One more thing I want to tell. Suppose in your lab, you're not speciating corns. You're reaching to the diagnosis of corns, but you're not speciating it. Then it belongs to this category, staph species, which is not speciated. So for those all, you can reliably do cefoxitin disdiffusion as well as oxacillin MIC. Oxacillin disdiffusion has a very limited uses. It can be used only for epidermidis, pseudo-intermediates, and Slippery. Other than these 3 species of corns, it cannot be used otherwise. One such question was, where can we use oxacillin salt agar? Oxacillin salt agar can be exclusively used for staph aureus. It cannot be used for other corns as well as Lugdunensis. Usually, staph aureus and Lugdunensis are have a common methodology of test, common breakpoints, but oxacillin salt agar can only be used for aureus, even not Lugdunensis. So we'll see a little detail about what are the various parameters for testing this penicillin and oxacillin resistance, and what are the differences between CLSI versus Eucust. So first we'll see what is the media recommended. So as far as MIC based media is concerned, CLSI has clear-cut instruction that we can use for MBDs, we can use cation adjusted Mueller-Hinton broth. For agar dilution, we can use MHA. If you're going to test for oxacillin, you have to add NaCl supplement, 2% NaCl supplement to it. Eucust has no specific such recommendations. It only mentions that Mueller-Hinton broth need to be used for an MIC based method. Regarding the incubation time, so what CLSI says that an average of 16 to 20 hours of incubation for MIC is required. You have to extend the MIC for oxacillin based test and Vancomycin. However, Eucust has no such extended MIC range. So in this, you can see that all the oxacillin based tests, these are all oxacillin based tests. and oxacillin salt agar. These have extended MIC. They all have 24 hours of total incubation. Cefoxitin based.
ए दोनों बॉक्सेस को निकाली है देखो
So, and cefoxitin, there is no extended incubation required other than cons species. So, the usual recommended incubation for a disc diffusion methodology is 16 to 18 hours, and for MIC it is 16 to 20 hours. What about disc diffusion? So, standard, other than standard 16 to 18 hours of incubation, we have extended incubation for cefoxitin disc diffusion, especially in cons. What about the breakpoints? What CLSI says that you have Staph aureus complex that includes Staph aureus, argenteus, and Switzer. Other than that, lugdunensis. If you get any of these identification, you have to use the breakpoints recommended for Staph aureus. UCAST have additional list to add to it. It adds intermedius, pseudo-intermedius, and coagulans, slippery coagulans to the list. That other than Staph aureus complex, we can use these three cons also as a breakpoint of Staph aureus. One major difference when you are going to test for penicillin susceptibility in Staph aureus is, for especially for the disc diffusion method, one major difference to note down is CLSI recommends that the penicillin disc to be used is a 10 unit disc. On contrast, UCAST has the breakpoint involving only 1 unit disc. So you have to decide which one for this, which one you are going to follow. Depending on the strength of penicillin disc you are using, you have to subsequently use the same breakpoints. If I am using a 10 unit disc, I have to use the breakpoint provided by CLSI, that is 29 or more is susceptible. If I am using in my lab as 1 unit, I have to use this breakpoint. I can't mix and match. I can't use a 10 unit disc and unknowingly start using 26 of UCAST as the breakpoint. This is something to be very careful of. Regarding the recommendations of penicillin, what CLSI says that the MIC based method of penicillin as well as the disc diffusion method, if combined with the fuzzy test, that is a sharp margin or the fuzzy margin, they are equally reliable. But UCAST is of view that the disc diffusion test of penicillin with the fuzzy test is more reliable than the actual MIC. CLSI recommends about test which detects beta lactamase production, or in rare scenarios when you get a MIC in the susceptible zone and you want to report penicillin as susceptible for Staph aureus, you must do an additional PCR testing for blazedzin before reporting it as penicillin susceptible. Must do a beta lactamase testing before reporting it as penicillin susceptible. However, UCAST has a clear-cut view. They tell that beta lactamase detected tests like nitrocephin, etc., are not reliable and should not be done. So, can we start the next?
Poll 14.
Yes.
Okay.
So we have a short poll. We have a 2-question poll. We'll get 1 minute of time.
Polling start. 1 minute of time. Thirty seconds left. Time's up. Polling is closed down.
Can we see the results?
Yeah, I displayed.
So for poll number 1, the question was MEXI-mediated MRSA can be detected by all of these mechanisms except which one? Majority 77% have voted for latex agglutination test. And the next question, MEXI strains have which combinations of cefoxitin susceptibility as well as oxacillin susceptibility? 49%, the majority goes for both should be resistant. So the first one, the majority of the people are right. We'll see the explanation for that. So for MEXI-mediated strains, we usually get cefoxitin as resistant, but the oxacillin can be susceptible. Okay, we'll come to the explanation of both the things. So basically, till now we were discussing about penicillin susceptibility. What about susceptibility to other beta lactams? So the susceptibility to penicillin is stable penicillins, which includes ampicillin, amoxicillin, those classes that they are called as penicillin is susceptible penicillin. So for these classes of penicillins, penicillin test is a reliable test. But other than that, like beta lactam combination agent, lactamase combination agents, then penicillin is resistant penicillins, the oxacillin, cloxacillin group, and subsequently other beta lactams, they can't be reliably tested with a penicillin test. For which of this will test for oxacillin resistance. So the most common mechanism of oxacillin resistance or methicillin resistance is mainly mediated through MEC-A. For MEC-A, we can do either oxacillin MIC if your lab permits, but every document says that testing for cefoxitin can very reliably predict MEC-A resistance. So among the cefoxitin tests available, we have cefoxitin disc diffusion and we have cefoxitin MIC. Both the tests can reliably pick, a cefoxitin based test can reliably pick MEC-A mediated resistance, but it's not always a MEC-A mediated resistance. The another analog of MEC-A mediated resistance is what we called as MEC-C. Now, what is so important about MEC-C? The important part is, however, these strains are MEC mediated, so they are cefoxitin resistant, but they can appear oxacillin susceptible. And even if the tests which can reliably detect MEC-A mediated resistance other than susceptibility testing test, like MEC-A PCR and any test, because what MEC-A causes, it causes alteration in PBP, produces a completely new analog called as 2A. So detection of any test which can reliably detect PB2A as well as the MEC-A PCR, they can very reliably, they are very gold standard kind of tests for detection of MRSA, but only if it's mediated through MEC-A. In those rare scenarios where it is not mediated through MEC-A, those tests like MEC-A PCR and PB2A detection methodologies like the latex agglutination test available for PB2A won't be able to pick it. One such is MEC-A. Plus, if you are using oxacillin only in your lab, you're not testing oxacillin other than oxacillin cefoxitin in your lab, you're doing only oxacillin MIC based test, you may be missing those. Plus, if there is a mismatch between cefoxitin and oxacillin, it creates a confusion in the mind of the microbiologist. Okay, we'll discuss how we sort out these discrepancies. So suppose let's discuss a panel, a testing methodology which detects both. So automated system example Vitec detects cefoxitin MIC as a screen and oxacillin MIC also. So what if your Vitek gives result in which both came as susceptible? Then what would be your next step? Nothing to be done. It is quite reliable. Both are agreeing. So the interpretation would be it is a MSSA. What about both came resistant? Cefoxitin MIC screen got positive as well as oxacillin MIC got positive. In those cases, again there is nothing to be done. Both are in agreement. Will reliably report it as MRSA. Suppose in two different scenarios, we have a mismatch between oxacillin and cefoxitin MIC. Our oxacillin MIC is coming as susceptible and our cefoxitin MIC is coming as resistant. This is a very common scenario if you are using a Vitek. The error in cefoxitin testing is this is the most common scenario. In this scenario, what should be done? Should we report it as MRSA? Should we report it as MSSA? What should be done? So the advice is don't report at this stage. What you need to do, first you should check for the purity of the isolate, whether your isolate is pure. You have to do a repeat test with some different methodology. Because our cefoxitin MIC came as resistant through Vitek, we'll do a tiebreaker test involving other methodology of cefoxitin. So we can do a cefoxitin disc diffusion test. Alternatively, you can do a cefoxitin E-strip, etc. things, or a MIC by other broth microdilution method, conventional. And then you look for the result of cefoxitin. Suppose your tiebreaker test comes as susceptible, cefoxitin disc diffusion comes as susceptible, and oxacillin MIC was already susceptible, you should report it as MSSA. But what if my tiebreaker test after checking the purity of the isolate came as resistant? So we have a scenario in which cefoxitin disc diffusion is resistant and MIC is resistant and oxacillin is susceptible. That is what we discuss now. It's a case of MEXI mediated MRSA. Okay. So if cefoxitin disc diffusion as well as MIC is resistant, oxacillin is susceptible, we can reliably say it to be MRSA with MEXI mediated, possibly MEXI mediated. This is the CLSI, what CLSI says about it is cefoxitin resistant and oxacillin susceptible. Consider a different scenario when oxacillin came as resistant, but the cefoxitin came as susceptible. We'll do the same methodology because our oxacillin MIC is coming as resistant. First we'll look for the purity of the plate of the isolate. Then we'll do a alternate methodology test in which we'll do oxacillin testing. So if it's a Staph aureus strain, we can do oxacillin screen agar, quite reliable. And then we'll see whether what my oxacillin screen agar report is. Suppose my oxacillin screen agar came as susceptible. It is showing susceptible oxacillin. Then cefoxitin MIC is susceptible, oxacillin screen agar came susceptible, I can confidently report it as MSSA. What if my oxacillin screen agar also says it to be resistant? Now I have oxacillin screen agar in support of resistance and MIC, and we have a cefoxitin MIC which is susceptible. So a scenario in which oxacillin is resistant and cefoxitin is susceptible, quite reverse of the MEK. This is what we called as BORSA, borderline oxacillin resistant Staph aureus. This is a non-MEK mediated mechanism of resistance. There is no MEK-A expression, there is no MEK-C expression. Then what is the main reason? So what UCAST has to say on this? So occasionally the MIC values can be high in absence of MEK gene mediated resistance. Those strains are called as BORSA. Usually they have low level oxacillin resistance, and it's mainly because of hyperproduction of beta lactamases. There may be occasional point mutations, but it is usually due to hyperproduction of beta lactamases. They are not MEK mediated. So MEK-A as well as MEK-C gene is negative. Because it is not MEK mediated, that's why cefoxitin most of the time comes as susceptible. Because cefoxitin is more accurately a marker of MEK resistance. What do we mean by or what we see as the result of oxacillin, whether it is resistant or cefoxitin resistant or susceptible, we can predict the susceptibility of penicillin is stable penicillins, which includes anti-staphylococcal penicillins like oxacillin, cloxacillin, dicloxacillin, napcillin. It can also predict susceptibility of beta-lactam combination agents like amoxiclav, ampisulbactam, piptas. It can also predict the susceptibility of oral and parenteral cephins, but beware, UCAST has a specific comment that it doesn't predict susceptibility to cefixime. It doesn't mean that every cephims we can use as an anti-staphylococcal. Cefixime, ceftazidime, avibactam, ceftibutane, and ceftolozane tazobactam has no anti-staphylococcal activity, so they won't be effective. Other than this list, rest all cephims have anti-staphylococcal activity and can be given in those cases. So Sanford has clearly clear recommendation on this, that for ceftibutane, for cefixime, for ceftolozane tazobactam, for ceftazidime avibactam and ceftazidime, it is unreliable. So we should be careful on that. Then it also predicts our susceptibility to carbapenems. All the carbapenems has anti-staphylococcal activity, and if it's an MSSA, and so suppose, what is the importance of knowing these informations? So the importance is, suppose I have a dual infection, as sir told in his last explanation. Suppose from blood I am getting a Staph aureus, which is a MSSA. However, in the urine or some other specimen or some sterile fluid specimen, I'm also getting a E. coli. So my clinician is asking me what to do. Should I treat it with cloxacillin, treat it with, so should I give cloxacillin? You have reported MSSA. The drug of choice usually lands up in cloxacillin. Cloxacillin and my E. coli is susceptible to piptas. So should I give a combination of cloxacillin and piptas? So what do you people say? This can be given as a reliable therapy, cloxacillin along with piptas. Anybody can mute and let me know. Cloxacillin for MSSA and piptas for E. coli. Can we give this combination?
Only piptas.
Only piptas.
Yes, exactly. By this information, this is the reason why we discuss this, because we should know that what are the various spectrum a MSSA can be susceptible to. It has so many gram-negative or coverage also, which are also coming as susceptible. So those can be used as a single therapy to cover gram-negative as well as gram-positive. UCAST, however, has a little opinion. It tells that if you're going to use cefotaxime and ceftriaxone as a therapy for anti-staphylococcal role, you should consider it always as susceptible increased exposure. Means cefotaxime and ceftriaxone should be given at the maximum doses recommended if you are going to use it as an anti-staphylococcal activity. The MRSA isolates, they may be susceptible to 5th generation cephalosporins like ceftarolone and ceftobiprole. So they need to be additionally tested. They need to be separately tested for these. You cannot give blindly 5th generation cephalosporin to any MRSA. They have anti-MRSA activity, but that need to be documented through susceptibility testing. So how we are going to interpret, suppose we have a comparative thing on penicillin susceptibility, cefoxitin and ceftarolone susceptibility. Suppose all three came susceptible. So what should be our interpretation? That penicillin predicts the susceptibility of what groups? The penicillin susceptibility more reliably predicts the what group of penicillins? It usually predicts the susceptibility to
Penicillin stable penicillins. Penicillin A is stable penicillin.
Yes. So not penicillin stable.
Penicillin A is
beta-lactams.
susceptible.
Penicillin susceptibility, it detects mainly penicillinase labile penicillins,
Labile penicillin.
and it includes the group of aminopenicillins, that ampicillin, amoxicillin, piperacillin, ticarcillin, carbanicillins. Those are all penicillinase labile penicillins. What about cefoxitin or oxacillin? It predicts the susceptibility of penicillinase
Stable.
penicillins or stable penicillins and BL-BLI combinations and carbapenems and oral and parenteral cephenes. What
Right.
about ceftaroline? Ceftaroline should be additionally tested in cases of MRSA.
MRSA.
If everything is susceptible, I can say like that my staff is susceptible to everything. Suppose I have a penicillin resistant, I have got a cefoxitin susceptible, and suppose I have got a report of ceftaroline also. So what can I interpret of that? That other than penicillinase labile penicillins, rest all beta lactams are susceptible for my strain. Similarly, if it's cefoxitin resistant, penicillin resistance means an MRSA, and my ceftaroline is susceptible, what can I predict by that? That
Resistant to all.
resistant to all, but still, because it is coming susceptible, I still use ceftaroline as an anti-MRSA drug. If it comes all resistant, no beta lactam is going to be effective. I have to look for other non-beta lactam options. What about this scenario? What if this scenario occurs? My penicillin is susceptible, my cefoxitin or oxacillin coming resistant, and my ceftaroline coming susceptible. Anyone can mute and let me know what
This
is
is non-MEC mediated MRSA.
So we discussed non-MEC mediated MRSA as
Borsa.
oxa resistant, and cefoxitin can be susceptible, can be variable.
Variable.
But it should be oxacillin resistant, and by our confirmatory test in the last slide we can do, finally we came to the interpretation that cefoxitin would be, final interpretation would be resistant. What about penicillin susceptible? Can we give penicillinase labile penicillins as a therapy? Can we consider them as?
No.
So the answer is this kind of result is not possible. Suppose your body or other systems are giving this result, don't trust that report, don't regard that report, disregard it completely. This is not possible. It's an erroneous report, flat. So can we have the next poll? Anyone from the technical team? Technical team? Anyone from the technical team? Can we have the poll?
Yes, ma'am, sure. I'm just launching the poll.
So we have a short poll.
Poll time is 1 minute.
1 minute. 2 questions are there in the poll.
Time start now. We have 1 minute for polling.
Okay, so time is up. We'll end the polling. So a nice group of people have replied it correctly.
I shared the result.
Okay.
I displayed.
So it's a easy question. We have just discussed this, that if you want to take the resistance of all the beta lactams, that my isolate is resistant to all the beta lactams available, we can simply use this combination, that it can reliably detect the test. As you can see here in the question, it was mentioned in Staph aureus, that gives the clue to the next. Ceftaroline for all are true except ceftaroline has breakpoint for all Staphylococcus species. It is effective for MRSA if susceptible, and if SDD, what is the dosing regimen? So by this question, we come to know that ceftaroline has a susceptible breakpoint as well as a susceptible dose dependent breakpoint. It doesn't have any intermediate breakpoint. There are only 3 SDDs mentioned in CLSI. Among these, one such is ceftaroline for Staph aureus. It has no breakpoint available for non-aureus isolates. Cons, it has no breakpoints. The breakpoints are exclusively for Staph aureus. Okay, and this is the regime what we do. As we all know, the standard dose is 600 milligram BD. How we work on an SDD isolate? Either you increase the dose or you increase the frequency. So we do an extended infusion. We all know beta lactams are usually time dependent. So we do an extended infusion that increase the efficacy and we increase the doses. So by that, even an SDD can be effective. So a short poll, only one question, or we can skip this poll. Or can we have this poll quickly? Nikhil?
16 or poll 17?
16, 17, both you can have, or one by one you can have.
One by one.
Okay, 16 you have, only one 6. It's a quick poll, only one question.
30 seconds.
Poll 16 launched. Time is 30 seconds.
It's an easy poll. So
Time is up. Time is up. Polling is end.
So a majority 65% or 66% have.
I'm sharing the result.
Yes. So a majority 66% have opted for the option B. Yes, it is the correct option. So the purpose of this is to have this idea that Staph aureus and cons have variable susceptibility breakpoints for vancomycin. So this is the main idea. They don't share a common breakpoint. They have a variable breakpoint where cons is having a higher breakpoint than Staphylococcus aureus. So what is there? There is no distribution breakpoint. Vancomycin distribution for Staphylococcus is highly unreliable. It cannot differentiate in between Visa and Vancomycin susceptible strain. So it is not recommended at all. The only thing available is MIC based detection method that is preferably to be done by a broth microdilution method. So what are the various methodologies to detect vancomycin? We can do it by vancomycin screen agar dilution also some places do, and broth microdilution. The standard of detection is broth microdilution. Screen agar has a major limitation. We use 6 microgram per ml plate, single plate. It has been found that those who are having a MIC of 2, this group, they can be reliably picked. They are inhibited. Those inhibited, we take it as susceptible. The MICs of 8, they always grow on 6 microgram screen plate. So they can be reliably picked. We can tell that it is this group, we can easily tell this resistance pattern. But this group of 4, those who have a MIC of 4, they don't grow on this screen agar, and that group we can easily miss. We can think that it is a vancomycin susceptible staph aureus, but it may be a case of intermediate susceptible staph aureus. Because of these major limitations, vancomycin screen agar is usually discouraged, not used. We must go for broth microdilution method. And one more important point is about the therapeutics. So this is about laboratory parameters. One important aspect of the, treatment wise, if you get a vancomycin MIC of anything above 1, that is 2 or more than that, 4, 8, we can reliably say it is intermediate, visa or resistant. But an MIC of 2, the final interpretation and the report you will be releasing is that it is susceptible, as the breakpoint is 2 or less than that. But can we use those for those treatment of those MRSA strain? Can we use vancomycin reliably? What's your take? Anybody can mute and say? I can unmute and say. So if my vancomycin MIC comes out to be 2, we use the breakpoint 2 is susceptible. So I reported that
Not reliable. Not reliable.
Yes, it is not reliable. Even if your report is going to be susceptible, you have to inform your clinician with a comment below your report that even if it is susceptible, it is not going to be therapeutically reliably successful. So in those cases, you have to use, so UCAST has this recommendation, as well as Stanford and other guidelines have these recommendations. So if you get a MIC of 2, that is more than 1, you should not use vancomycin as a therapeutic option, because there are high chances of those strains leading into a therapeutic failure. You should opt for an other than vancomycin MRSA treatment methodologies. So this is what UCAST writes. Its glycopeptide MIC should be determined by BMD, and vancomycin of 2 cannot differentiate properly between wild type and resistant ones, and there is a impaired clinical response, should not be used as a therapeutic option. Next, we'll discuss about inducible clindamycin. So inducible clindamycin can be detected either by disc diffusion or it can be detected by MIC based methods. Both can be used. So how we do? By disc diffusion method, we use a erythromycin disc, we use a clindamycin disc. On the agar plate, we place them adjacent to each other. What should be the distance between these two placements? CLSI says that the distance can be in the range of 15 to 26 from center to center distance, and UCAS says that it can be 12 to 20, but it should be adequately spaced. Okay, you have to keep it following these two in mind. Once we keep them, and the incubation should be 16 to 18 hours, a standard incubation. What about MIC? In the microtiter well, we'll add erythromycin, we'll add clindamycin, a mix of it, and the isolate, and look for whether any growth is coming in this combined well or not. This is how we do testing. And the incubation is a little extended. What is normally recommended of 16 to 20, it is 18 to 24 hours. How we interpret it? So disc diffusion, there are 2 recommendations for interpretation. What is the one and the most common recommendation? What we all know, there should be a blunting. What is blunting? Suppose we place a erythromycin disc close to a clindamycin disc. The isolates which are present here are susceptible, so we have nice clear zone. But the isolates which are present here, in them one resistant phenotype is getting induced by a macrolide erythromycin, and because of that resistant phenotype getting induced, those isolates are no more susceptible to clindamycin. So instead of giving a zone like this, they grew more into it. Okay, so that is what we call as flattening or D-test. This phenotype is what we called as MLSB phenotype. Macrolide, lincosamide, streptogramin B phenotype. Okay, so it D-test detects a MLSB phenotype. What is the other methodology? It may not appear as a blunting. You may see minute colonies in between the zone, clear-cut zone, not on this side, but here the zone may be complete, but you can see.
Excuse me, the earlier slide, would it not be MLSB inducible?
Yes.
It will be MLSB inducible.
Yes, yes.
Yeah. Thank you.
So you can have discrete colonies inside the cleared zone. You may not have a blunting, you can have isolated colonies. Even this is taken as inducible clindamycin resistant positive. Okay, so there it may be D zone or it may not be D zone with a growth inside the clindamycin on side of the erythromycin. As far as MIC is concerned, if any growth is seen in the MIC well where MIC both are placed, it's taken as ICR positive. Usually we see an ICR when erythromycin is resistant. So macrolide is usually resistant. Sometimes with intermediate erythromycin also it can be, but usually it is resistant. Clinda can be variable. So most important thing is we need not be worried about ICR if my erythromycin is resistant and Clinda is also by breakpoint resistance. If by breakpoint Clinda is resistant, doesn't matter if ICR is positive or negative, we report it as resistant. We are more concerned if clindamycin is susceptible. Before reporting it to be susceptible or intermediate, we should look what my erythro is and what my ICR results is. So if my ICR is positive, I'll change my clindamycin resistant as resistance, because if you treat those systemic infections with clindamycin and the patient has prior exposure to erythromycin that may not be available with you, the induction may be there and the clindamycin may be resistant in vivo. However, that is true for systemic infections. The recommendation says that you can still use clindamycin for less serious skin and soft tissue infections, because such treatment methodology is highly is no reliable data is there that even in treatment of skin soft tissue infection, clinda may develop resistance. Now we'll move to the Enterococcus, the second important organism in this group. So can we start the poll 17? Nikhil?
We are starting the poll 17. Poll 17 is start. We have 1 minute for polling.
We have sought 2 questions in it. So its poll is going to end in some time.
25 seconds left. Time's up. Polling is closed.
Okay, so I can see.
I'm sharing the results.
I can see for poll 1, most of them have picked the last option. Okay, and for poll B,
I shared the result.
The same last option. Now we'll discuss the questions. So this is more of a clinical question as compared to a microbiology question, but this knowledge is very important for us so that we can reliably give advice to our clinical counterparts. So the question was, which of the following cephalosporins can be used for treatment of enterococcal infections? We usually think that cephalosporins we don't use for enterococcal infections, but there are specific guidelines and scenarios like serious enterococcal infections, which includes meningitis, endovascular infections like infective endocarditis, or other non-endovascular bloodstream infections. In those cases, what the recommendation says is the most common recommended therapy is ampicillin. We'll discuss that in the next slide. So yes, ceftriaxone can be very reliably given in as a combination therapy. Mind it, in special scenarios as a combination therapy uh, for treatment of those serious infections. I have a slide after that. I'll discuss on that part. The second question was synergism is exhibited in all of the following combinations. The synergism between gentamicin and ampicillin is going to work in among these. In what scenarios it is going to work? So many of us have marked the option D, that is both B and C, if high level resistant and ampicillin susceptible, if high level resistance susceptible and a low level. So synergism is going to work in all except in what scenarios it is not going to work. So the answer is, if our synergism test comes resistant, then it is not going to work. I'll discuss one by one the other options. Let's first move to the next first question what we discussed. Oh no, this is the HLG discussion. So how and all we predict aminoglycoside susceptibility? As well as Enterococcus is concerned, Enterococcus are intrinsically resistant to aminoglycosides. Okay, but this intrinsic resistant or constitutive resistance is usually of low level resistance. Why? Because aminoglycosides molecules are usually bigger in size. They cannot enter into the cell, and as they are protein synthesis inhibitors, they should enter the cell and act inside. But when you give a aminoglycoside with such an agent which can create pores in the cell so that they can attain higher concentration inside the cytoplasm, they can still act. That's why the synergism of aminoglycoside can work with any cell wall acting agents, which can destroy the cell wall and helps in their penetration into the enterococcal organism. So how can we say that this synergism is going to act or not? So it already has a low level resistance. If there is a high level resistance to aminoglycoside, then this synergism is not going to work. If there is no high level resistance, means only intrinsic resistance of low level is there in the organism, then we can expect a synergism to work. How to detect this high level resistance? So we do two types of tests. We either test for high level gentamicin or high level streptomycin. Why streptomycin and gentamicin separately? Because high level gentamicin testing, it tests for the susceptibility for all the aminoglycosides, amikacin, kanamycin, etc., except streptomycin. A HLG testing cannot predict high level synergy of absence for streptomycin. So that need to be additionally tested. But here I want to make clear that this is only in vitro testing. High level gentamicin means it is only in vitro testing. It doesn't mean that a high dose of gentamicin or a high dose of streptomycin would work in those infections. No. Even if given in a combination therapy, gentamicin and streptomycin is always given in the recommended therapy. So what are the various scenarios? How the synergy is going to work? We'll learn step by step. Suppose we have a synergy susceptible and we have a cell wall acting like penicillin or ampicillin also coming as susceptible. Then what's the scenario? In those cases, because both synergy is going to work and my antibiotic is susceptible, so both are effective on Enterococcus, so the synergism is going to act for sure. So what is the recommendation for those is, so I'll tell you, combination therapies we give in only serious enterococcal infections, that is meningitis, that is infective endocarditis or other endovascular infections, or serious non-endovascular bloodstream infections. we give a usual dose of penicillin G, we give a usual or a visual dose of routine dose of ampicillin, standard dose, along with a standard dose of gentamicin. Okay, I've already told the indications. What if the synergy comes out to be resistant? If the synergy come out to be resistant and my drug is susceptible, penicillin and ampicillin, synergism is still not going to act, because as I've told you, HLG came as resistant means synergism won't work. In those cases, there are various modalities we can use. Among such modalities, recommended modalities, one such is ampicillin in standard dose, and ceftriaxone can be reliably combined with it, or a imipenem can be combined with it in synergism and can be used to treat those infections. So ceftriaxone can be used for treatment of enterococcal infections. What if the synergism is going to work, but my penicillin or ampicillin is showing low level of resistance? The resistant breakpoint is 16 in both penicillin and ampicillin. So it's 2 dilution, 3 dilution and 2 dilution resistance. That is called as low level resistance of penicillin and ampicillin. So the working should be like that. Even if the synergism is there, it should not work because my cell wall acting is not acting. But no, the answer is it is still going to act. So low level resistance of beta lactam or penicillins with a active synergy, it is going to act. But the only thing is you should go above the standard dose. So standard dose is what?
Your PPT is not showing.
What happened? Screen has become black.
News.
Yeah.
Okay. So
Visible.
the usual doses of penicillin is 24, but in this case, we have to give us increased dose of
Pole 18 we are starting. We have 1.5 minutes for pole 18.
Wait. This slide is not over.
so 20
Okay.
other than 24, we have to use a higher dose. Other than 15, 12 dose of ampicillin, we have to use a higher dose. So we have to use a higher dose of ampicillin and a standard dose of gentamicin. Even if HLG is working, you don't use a higher dose of gentamicin. Our cell wall acting agent is having a low level resistance, synergism is not going to work. Go for alternative therapy. So this is Nikhil, can we have the poll?
Yes, pole 18 is launching. We have 1.5 minutes of pole 18.
We have a 3 question poll. Now is the last 10 minutes.
There 30 seconds left. Polling is closed now.
We are closing the poll. Let's see the results.
I displayed the results.
So first majority opted for option B, and majority of. So one by one we'll see the questions. So the first question is, all of the following statements regarding susceptibility testing of ampicillin and penicillin against Enterococcus are true. The options are: susceptible to penicillin, you predict the susceptibility of ampicillin. Second one is, you get ampicillin susceptible, you predict the susceptibility of penicillin. You get susceptible, okay, so amoxicillin and subsequently. So the answer is susceptibility testing to ampicillin doesn't indicate the susceptibility of penicillin. So the question was except. So how it goes, if we get a penicillin susceptible Enterococcus, then all the higher in the listed points are going to be susceptible. We can reliably predict their susceptibility. So if you're getting a penicillin susceptible Enterococcus, it is going to be susceptible to ampicillin, amoxicillin. It's all BL combinations like ampicillin sulbactam, amoxicillin clavulinate, even piptas, and also imipenem. Then same ampicillin susceptibility can also be extended, but if what about if ampicillin is going to be susceptible? Then ampi-susceptible means it's going to be susceptible to amoxicillin, ampisulbactam, amoxiclav, piptas, and imipenem. But the penicillin, if penicillin comes out to be resistant, can we say that ampicillin is also resistant? So the answer is no. If penicillin comes out to be resistant, ampicillin need to be separately tested. Penicillin susceptibility can predict ampicillin susceptibility, but penicillin resistant results cannot predict the susceptibility of ampicillin. And it is the ampicillin which is more commonly used for the treatment purpose, not penicillin. Penicillin is also sometimes used, but mostly is ampicillin. So those all places where we are using Vitek or an automated systems, they do penicillin MIC, but they don't do ampicillin testing. So if your Enterococcus faecalis is coming as penicillin resistant, it doesn't mean it is also resistant to ampicillin. So if your lab permits, if your situation permits, it is always advisable to additionally test for ampicillin. A mere simple disc diffusion test of ampicillin is enough. There are occasions in which penicillin can be resistant and ampicillin can be susceptible as well as therapeutically effective. The next question was, if any Enterococcus isolate is shown to be high level gentamicin resistant, what can we expect? Is it resistant to only gentamicin? It is resistant to genta plus other aminoglycosides. Is it resistant to all aminoglycosides, but streptomycin need to be additionally tested? Or we can predict that gentamicin, streptomycin is resistant, but others are, we cannot say. The answer is very clear. I've already discussed. For gentamicin HLG testing, genta and other aminoglycosides can be reliably commented, but streptomycin we can't. We have to additionally test for it. The breakpoints for all of the following which were there, the breakpoints are available for only Enterococcus faecalis, but not for faecium. Which among them is not true? So the answer is quinopristine, dalfapristine. For rest others, the lipoglycopeptides and the oxazolidones, tizolid, they have breakpoints for faecalis, but they don't have breakpoint for faecium. Quinipristine is not the scenario. So there are breakpoints which are only faecalis, then there are breakpoints which are only for faecium. So as far as faecium is concerned, we have quinopristine, dalfapristine that has breakpoints only for enterofaecium, that too for vancomycin resistant strains. On the other hand, lipoglycopeptides like dalavancin, telavancin, and ultravancin, they have Enterococcus faecalis breakpoint. Phosphomycin has a faecalis breakpoint for urine isolates as well as tidazolid. pneumonia, this is the most important concept of pneumonia is about penicillin susceptibility. Can we have the poll?
Yes, ma'am. We have a 1.5 minutes for poll 19. Time starts now. Thirty seconds left. Time is up. Polling is closed now.
We'll end and we'll see the results.
So the result?
So in the question 1, it was a great
Split.
confusion. So this
Results is split.
this is an important thing to discuss then. So we equally voted for option A and B. So what was the question was the MIC susceptible breakpoint for meningitis and non-meningitis isolates for Streptococcus pneumoniae. So the idea of this question is that we should be very much aware of this fact that Streptococcus pneumoniae has both meningitis as well as non-meningitis breakpoints. Okay, so they have separate breakpoints for meningitis as well as non-meningitis. And what is the difference? They should know that the meningitis breakpoint is always so much less than the non-meningitis breakpoint. So you may not exactly remember the values, but you should have the idea that they are different, and meningitis breakpoints are much lower than what non-meningitis isolates breakpoints are. That means there may be a particular isolate for which, if it's a meningitis, then my penicillin is going to be resistant, but it may still be working on a non-meningitis cases. So that's why meningitis have a breakpoint less and non-meningitis have a comparatively higher breakpoint. Okay. Then the next question was, all of the following statements regarding antibiotic susceptibility test of strep pneumoniae are correct. For CSF isolates, vancomycin can be tested by both disk diffusion as well as MIC based method. For a non-CSF isolate, for oxacillin Jones less than 19 mm, we don't report penicillin as resistant. The cutoff for oxacillin is 20 to report as susceptible, but we have to perform a MIC based test. For non-CSF isolate, the penicillin susceptibility should be reported in the clinical report for meningitis breakpoint as well as non-meningitis breakpoint. And if it's the non-CSF isolate, the oxacillin Jones are more than 20, then we cannot predict the susceptibility of penicillin. So the answer is yes, because it was an except question. So if a non-CSF isolate has oxacillin Jones size of more than 20, we can very reliably predict its susceptibility to penicillins, cefotaxime, ceftriaxones, as well as carbapenems. Okay. Similar question was there in here for meningitis isolates, like we just now discussed. that for meningitis, if you have a penicillin susceptible, you can simply extrapolate it for, don't need to test for cefotaxime, ceftriaxone, meropenem, predict it. Okay, but what for meningitis isolates, both penicillin and third generation cephalosporins, carbapenems should be tested by an MIC based method only, and then should be reported. Both the results should be reported. And the erythromycin predicts the susceptibility of azithromycin. The meningitis isolate for which oxacillin zone is on a higher side or MIC on the lower side, can we predict susceptibility to beta lactam? The answer is no, we cannot. Why? Because for meningitis CSF isolates, I'll tell the explanation in the subsequent slide. So how we test for the penicillin susceptibility in Streptococcus pneumoniae? So there are two modalities of testing. First, we'll see if my isolate is a CSF isolate. Okay, then I should do only meningitis based testing interpretation. If my isolate is a non-CSF isolate, like blood isolate or another RISP isolate, anything like that, then I should interpret it by both meningitis and non-meningitis breakpoint. What's the need for it? Because even if it's a non-CSF isolate, we don't know if the patient is not having a meningeal involvement. Plus, during the course of illness, it may go into the CSF and may cause meningitis. So that's why the clinician should know what should be the drug of choice if it's a meningitis, what should be the drug of choice if it's a non-meningitis kind of scenario. Now, meningitis presentation of penicillin, you cannot do any disc diffusion testing. Disc diffusion we do with a surrogate test called as oxacillin. We do a surrogate testing of oxacillin 1 microgram and we predict the susceptibility of penicillin and other beta lactams. But that is not true for meningitis isolate. So if it's a meningitis isolate, it should always be a penicillin MIC as well as third generation MIC, or if you want, you can do a carbapenem MIC also. For non-CSF isolates, we can do a oxacillin 1 microgram screen. If it comes as susceptible, that is more than equal to 20 mm, we can stop at that moment. We can report penicillins and others to be susceptible. Suppose it come out to be 19, that is resistant, we don't report resistant because it is unreliable. Then all the things, penicillin, ceftriaxone, cefotaxime, we need to be confirmed by MIC based method. That should be additionally tested. You cannot directly report it to be resistant. Okay. So the same thing I was telling, one important thing is that there is a breakpoint difference between many UCAST and CLSI both have penicillin meningitis and non-meningitis breakpoint, but their breakpoints are highly variable. What CLSI says that it keeps for meningitis 0.06 as susceptible, 0.12 onwards as resistant. So the same thing is retained by UCAST, but regarding non-meningitis, UCAST is completely different. It keeps the susceptible breakpoint as 0.06, the same as meningitis breakpoint, and anything above 2 is taken as resistant. 2 or more is taken as resistant. The in between ones are taken as intermediate. Okay. Similarly, ceftriaxones, third generation cephalosporins also have a meningitis, non-meningitis breakpoints. For CSF isolate, you report only meningitis. For non-CSF isolate, you report both because you don't know if CSF is CNS system is involved or not. Vancomycin, we have only susceptible breakpoints. So those which are higher MIC, that is a very rare and not reported till date kind of situation. So we go it as NS, non-susceptible category. Regarding beta hemolytic streptococci, this poll we can skip. What I'll tell is, so the question is, if should we do a routine testing of penicillin and MIC in cases of Streptococcus pyogenes? As Pallab Sri sir has already discussed on that, no, we need not, because resistant strains are not reported. Okay, but if your clinician wants to know about the susceptibility, we can still perform. In those cases, penicillin, either penicillin or ampicillin can be tested. both disk diffusion as well as MIC based methods, breakpoints are available, but not routinely tested because resistance is not reported. Regarding the testing, if your lab is not equipped with MIC based testing for Streptococcus, you don't have ST03 card available in your lab for Vitek testing. Even without that, you can do a series of testing for Streptococci. There are a long list of antibiotics for viridins, for beta group, hemolytic group of Streptococci, as well as pneumococci, including a screen of oxacillin for penicillin, which can be done by disk diffusion method. So even if you don't have a MIC based method, you can still, by disk diffusion, you can reliably report. This will very briefly finish. Okay. So M45 is a document we have already discussed. It includes infrequently isolated organisms as well as fastidious ones. Two fastidious organisms which are included, other than Streptococci, the two fastidious organisms included in M100 is Haemophilus influenzae, parainfluenzae, and Neisseria group. Other than that, in M45 we use non-fastidious ones which are not frequently isolated. We have Vibrio, we have Aeromonas. Breakpoints are available. The breakpoints are of enterobacterials, mostly, not mostly, all of them actually. So enterobacterial breakpoints are used for Vibrio and Aeromonas. Then we have Campylobacter, we have Helicobacter. Some pathogens like nutritionally variant Streptococci have their breakpoint. Hesse group has a breakpoint. Other species than influenzae and parainfluenzae of Haemophilus can be tested using Hesse group breakpoints. Then we have Pasteurella, Moraxella catarrhalis, diphtheria and other diphtheroids, erythropelostrix. Then potential agents of bioterrorism like Malai and Pseudomalai and Brucella. Breakpoints are there. And contaminants. This is very surprising, but yes, contaminant breakpoints are also available. A series of gram-positive bacilli and gram-positive cocci contaminants. Breakpoints are also available, but they should not be very rampantly used. Very strong clinical suspicion, multiple isolations, then only testing should be done and evaluated. So this would be my last slide on M45. Then we'll be having a subsequent discussion or intrinsic resistance.
Yeah.
Dr. Harita.
So here I wanted to just focus. See, all of you, what you do is you follow M100, and M100 doesn't have the breakpoint of Vibrio and very important pathogen like Burkholderia pseudomalai. Burkholderia pseudomalai, which is so frequent in South Indian places, and also Vibrio, which we frequently get. Aeromonas, for example, we frequently get in our laboratory. So there is another document called as M45, which is for infrequently isolated organism. So it has the breakpoint and testing methodology details. So because of the times lag, we had planned to take this session in detail, but because of the time gap, we have to wind up. So not all organisms in this document are important because we do not get them frequently. 2-3 organisms such as Vibrio, Aeromonas, and Burkholderia pseudomalai. So these organisms you have to look into.
And infective endocarditis patients, you may want to do HESEC testing. Testing is not recommended for HESEC, but only if it's not resolving on the recommended testing, then you may.
Then you have to do. Okay, it has the breakpoint of some of the contaminants, which is not very important. So this can be, you can skip this, but at least the pathogens which are important, you have to go through. Okay, so you will get M45 document in various sources, and if you get, then you go through at least Vibrio and Burkholderia pseudomalai.
Vibrio Aeromonas have exactly enterobacterial breakpoint. The only problem is they are not updated. So its last update of M45 came in 2015. But after that, subsequently, Enterobacteria's breakpoint they have upgraded. So the which got sacrificed is the Cipro and Levo. We all know that the breakpoints have tremendously increased. From 21, they have increased to 26 diffusion. So because of that part, this for M45 they are still having a low breakpoints, but otherwise it is ditto. The breakpoints are ditto same as Enterobacteria's for Vibrio and Aeromonas.
Okay. So now we will have another important session, the intrinsic resistance uh, scenarios, because Vitek, for example, will test 15-16 antibiotic for various gram negative, like if you use the panel 280 in Vitek or 281 in Vitek, whatever is the identification, there are various antibiotic for which the organism may be intrinsically resistant. For example, Stenotrophomonas, Vitek will test in 281 panel around 15-16 antibiotics, but Stenotrophomonas breakpoints are available only for 4 or 5 antibiotics. The rest all, most all, it is intrinsically resistant. However, Vitek printout, when you take it, it doesn't clearly mention intrinsic resistant uh, situations. So it is our duty to identify them and filter out them. Otherwise, it may go as a susceptible report to the clinician also, which is extremely dangerous. This is first situation for which the intrinsic resistance reports are important. Another situation for which you have, another reason for which you have to give intrinsic resistance message